Hearty welcome to the 41st session in our Learn from the Legends International Webinar Series in Neonatology, organized by NNF Kerala, IAP Neocon, and NNF Thrissur. Today we have the opportunity to interact with a legend from Spain. Professor Manuel Sánchez Luna, Complutense University of Madrid, and President of the Spanish National Society of Neonatology, Seno, Spain, who will enlighten us on lung protective strategies in the immature newborn. We are fortunate to have learned moderators, Dr. C.N. Kamalaratnam, Professor and Head of Neonatology, ICH and Madras Medical College, Chennai, and Dr. Neeraj Gupta, Additional Professor, AIMS, Jodhpur. Thank you and welcome to the webinar series. Over to Dr. V.C. Manoj for further proceedings. Thank you.
Hello everyone. Good morning, good evening, good afternoon, depending on whichever part of the area you have joined from. Welcome. Today we have another legend with us, Professor Manuel Sánchez Luna. His biosketch extends to pages. So on his own request, I have just summarized his biosketch. He is a professor of pediatrics at Complutense University of Madrid, Spain, invited short-term scholar at the Colorado University, Denver since 2005, invited professor at the Toronto University, Toronto since 2013, and who has extensive interest in bronchopulmonary dysplasia, respiratory physiology, sepsis, shock, personalized nutrition, etc. Friends, if you remember, he is not somebody who is not new to us in the Learn from the Legends, because he gave us an elegant lecture last year on the recent advances in high frequency oscillation. Some of us who have already started using it, the targeting volume in high frequency oscillations. So he is a learned legend. We are very fortunate to have you, sir, here with us. He is a faculty and chair at the International National Congress and Workshops, has more than 250 publications in national and international scientific journals, more than 200 books to his credit. He is the president of Spanish National Society of Neonatology from October 2019. He is the ex-president of the Union of European Neonatal and Perinatal Society, UNPS, whose webinars we continue to watch now thanks to the pandemic. He is the ex-president of the International Neonatology Association, INA. He is the ex-vice president of the World Association of Perinatal Medicine, WAPM. He is an MBA in medical. He is not only a doctor, he is an MBA in medical governance and hospital administration. He is a regular fellow of the International Academy of Perinatal Medicine. He is an international advisor to WHO on various counts for neonatal nutrition, group of growth and anthropometric neonatal study, intergrowth 2021, and anthropometric group, small and sick babies and every newborn results framework, WHO, etc., etc. So if I keep on reading this, we'll be taking up the time, and on his own request, I will not spend more time on this. So let us hear from the legend on a very important topic, lung protective strategies when it comes to the smaller babies. As he is right now in another session and he will be joining in another 10 minutes, he has given me the video. I'll play the video from my side. As soon as before the video is over, he is going to join us as well. So over to Professor Luna. Sorry.
Hello, this is Manuel Sánchez Luna from Madrid, Spain, and I would like to thank to the scientific committee to give to me the possibility to enjoy with all of you during this time to talk about lung protective strategies in the immature newborn infant. Well, today I must say that we are not talking anymore of the old Guillain-Barré disease. Why is this? Well, because remember that that disease occurs because immature babies were connected to the ventilator without surfactant therapy, and the lungs were exposed to very high oxygen concentration. Today, we are having more and more immature babies. The respiratory problems used to be less severe because we are giving antenatal steroids, most of them. We also give less invasive respiratory support. So less babies are exposed to the immature lung to the invasive mechanical ventilation. And most of the new ventilators are controlling the tidal volume, what is the most important factor related to the VILI, the ventilator-induced lung injury. Also, we have the possibility to give very early surfactant therapy. So in total, what we are seeing today is what we call respiratory distress syndrome of immaturity. That is a good combination of very immature of the lung, very immature of the baby, and the use of non-invasive respiratory support. So less aggressive therapy, less severe chronic respiratory problems in the babies, probably. So let's go together to the labor and delivery room to know what today we are doing to prevent this trauma after delivery. Well, there are two steps in this prevention. Number one is to control the oxygen toxicity. Well, you know very well from many years that the oxygen concentration can produce trauma and damage into the lungs of immature babies. Well, in this slide, you can see in your left-hand side a control group of newborn rats that were breathing air during 21 days. Well, in your right-hand side, you can see the lung of newborn rats breathing oxygen at 60% of concentration during 21 days. And you can see how the lungs are very damaged with a lot of simplification of the air spaces, resembling that lung of babies with bronchopulmonary dysplasia. So controlling the oxygen is extremely important from the very beginning after delivery of the babies. But also not only the oxygen. Today we know that the use of very large tidal volumes or not producing an adequate recruitment of the lung can even more damage the immature lung. So today we use this kind of pulmonary function monitors to control not only the oxygen saturation, but also the tidal volume that we are producing, or the baby is producing by themselves, and the tidal CO2. That is going to be a very good signal of the lung perfusion, where the lung is well recruited and perfused. Well, in this video from Gonzalo Ceballos from our institution, you can see a very immature baby given the possibility of breathing spontaneously with a mask on CPAP. You can see in this monitor, pulmonary monitor, that you have a tidal CO2 signal, and you can look at the tidal volume that the baby is producing spontaneously. So you have a very good combination of data showing you that babies will recruit, the baby is breathing spontaneously, and the babies will perfuse of the lung. Well, in this other video, you can see another very immature baby where the person who is with the baby is given non-invasive ventilation, but in positive pressure ventilation. So in this other situation, you can see that there is tidal volume, but it's not end-tidal signal. So there are two possibilities. One is that the baby's lung is not well recruited, or the baby's lung is not well perfused, or the combination of the two. So in this baby, probably we need to do something else to improve the lung recruitment, the stabilization of the functional residual capacity after delivery. So I can show you how important is to use this probably new strategies that's going to help you a lot to know how the baby's lung is beginning to breathe in a good condition. So Gonzalo Ceballos in our institution did this very nice study. Well, in babies of less than 32 weeks gestation, he went to the labor and delivery room and randomized to be used the pulmonary function monitor in half of them, with having the possibility of looking at the screen and knowing exactly how the lungs were perfused and ventilated. Well, in the other half, randomized, the babies were also connected to this pulmonary function monitor, but the screen was masked. So the person who was given the resuscitation were following standard criteria of moving the thorax of the baby and looking only at the oxygen saturation. So at the end, we analyzed the two groups, the babies, and we compared data from the pulmonary function monitor, and you can see how in the group of the babies where the screen was masked, the tidal volume that were used was statistically significantly higher compared to the group of the babies where the screen was visible. So the person who was looking at the monitor were trying to use the lower tidal volume as possible to prevent lung injury. And you can see how in the group of the babies where the screen was not visible, the tidal volume sometimes were higher, even than 9 ml per kilogram of body weight. So the consequences probably is going to be in the large time. But look at this also. The babies in this group of the monitors mask of the screen were tried or trained to be hyperventilated with a lower end-tidal CO2. So the risk of not only over the extent of the lung, but also to hyperventilate was a combination of the two. You don't look at the lung of the baby while the baby is resuscitated. And this is important. Okay, we know from many studies that the larger is the tidal volume, the higher the risk to produce damage in the lung of the very immature babies, but also is also a risk, a higher risk to produce damage into the brain of the baby. So if you look at this study of Gonzalo, you can see how the larger tidal volume used mostly in the babies of less than 28 weeks gestation, where the risk to produce damage is much higher compared to babies bigger or larger. So this study done in Australia, you can see how when these investigators divided the babies, immature babies, the labor and delivery room, where the tidal volume was monitorized, and they divided the group, the babies, in those where the tidal volume was used higher than 6 or lower than 6 per kilogram of body weight. Then they saw that in the group of the babies where the tidal volume was larger, the number of babies who developed intraventricular hemorrhage was statistically significantly much higher than the group of the babies where the tidal volume was lower. But mostly, the kind of the intraventricular hemorrhage was different in terms that in this group of the babies where the tidal volume was higher, the intraventricular hemorrhage was more severe, grade 3 or 4. Well, after the stabilization in the labor and delivery room, we moved the babies to our NICU and we tried to do not intubate any of them. If we can, fantastic. So these are many of the possibilities that we can use. We can use nasal CPAP, we can use non-invasive ventilation, and in most of the institutions, nasal CPAP probably is the first step. Well, look at this very nice study published 2 years ago from a survey in different NICUs in the United States. As you can see from the last 10 years, in more and more NICUs in the United States, more babies are given non-invasive respiratory support in the first 24 hours after delivery. So this is a philosophy that in most of hospitals are probably following in many different hospitals. But at the same time, in these hospitals where most of the babies were treated with non-invasive respiratory support during the first 24 hours, the number of babies who finally developed BPD or died were decreasing. So, of course, we can't say, because this is just a survey and an observational study, that there is a clear relationship between the two. But something probably is behind that. The use of the lower respiratory support is going to improve probability of survival of the babies at the end. Well, but how can we know if a baby during the first few hours after delivery is going to success using nasal CPAP, for instance? Well, this study coming from Poland is very attractive in terms that if you look at the babies during the first few hours after delivery and you look at the FIO2, then probably you can better select who is going to fail using nasal CPAP and will need to be given surfactant or intubated. Well, in this study, they observed different factors, and after the analysis, they saw that the group of the babies that the nasal CPAP failed, FIO2 during the first hour after delivery, or FIO2 during the second hour after delivery, was statistically significantly higher compared to those babies who were doing well with the nasal CPAP, giving to us the idea that the sicker is the baby, the more aggressive therapy probably is going to be needed. For example, giving surfactant or giving another kind of therapy. So, which kind of non-invasive respiratory support is better to the other? Well, there are many possibilities today. You have in the market of devices, different kind of them. But look at this meta-analysis comparing different strategies like the PAP, high-flow nasal cannula, standard variable flow CPAP, synchronized nasal ventilation, non-synchronized nasal ventilation, and high-flow, high-frequency nasal ventilation. Well, you look at this study, then most of the devices, most of the ways of giving non-invasive respiratory support are positive in terms of good results. But if you look, BiPAP, high flow nasal cannula are in the group of ways of giving non-invasive respiratory support that is going to be not very positive in terms of superiority compared to the standard non-invasive ventilation or variable flow CPAP. Well, in this meta-analysis, they demonstrated that in babies around 25 weeks gestation, the better way to give non-invasive respiratory support is synchronized nasal ventilation. And in the group of the babies that are close to 28 weeks, then both synchronized or non-synchronized nasal ventilation probably are going to be superior compared to other methods of giving non-invasive respiratory support. Well, what can we say about different kind of CPAP, which are the most frequently devices? Well, for many years, we have seen that many different kind of CPAPs appears, but we know that even today, and this is very nice study of meta-analysis comparing the standard bubble CPAP versus other kind of CPAPs. And these authors review and analyze that using bubble CPAP is probably more effective compared to standard regular CPAP to prevent failure of CPAP during the first 7 days after delivery. So keeping this in mind, probably the only reason why most of the hospitals hide away from the CPAP is because of the risk of nasal injury. Well, as you can see, one of the problems with this kind of devices compared to other standard CPAPs is the higher risk of nasal injury. So it's not by itself the device, but probably the interface where we are using this kind of devices. The problem related to many times the fail of these therapies. And this is probably the reason why in many institutions, some babies are not given standard CPAP and they're given other methods of respiratory support, yes, because of the risk of nasal injury with standard devices. And because of this appear different kind of devices or interfaces to give non-invasive respiratory support. So today, for example, we have some evidence that using nasal mask compared to standard nasal prongs are superior in terms of risk of needing intubation within the first 72 hours after delivery. So in our institution today, we are using a lot of nasal mask because you can reduce the risk of trauma, nasal trauma, and they are probably as effective as the standard binasal prongs. And as you can see in this meta-analysis, the risk of trauma is much lower in the use of the nasal mask compared to prongs, but also the need of surfactant therapy. So this very attractive new way of giving respiratory support non-invasively probably is going to be superior compared to the standard binasal prongs. What about the high flow nasal cannula? Well, in many institutions, they are using to give non-invasive respiratory support this high flow nasal cannula because the interface is more friendly to the baby, is more friendly to the nurses, is more friendly to the doctors, and is at the end more friendly to families. So these kind of interfaces are using a very small, some prongs that produce less trauma. They are smaller and very well tolerated. But one of the problems is that with this kind of devices, the distending pressure is not controlled and can be ineffective or can be dangerous because of the pressure is not well programmed and is unpredictable because it depends on the leakage and depends on the respiratory effort of the baby and depends on the flow that you are giving to the very immature baby. So when we look at the evidence behind the benefits of using this kind of high flow nasal cannula in our very immature babies, we need to be very caution, and we have to be at least taking a look about this kind of response to these devices. So Dr. Markey in Canada, he did a very nice randomized study in babies of more than 1,000 grams. Well, they compare what they call the proportion of primary support looking at the time. So the response of babies who were on nasal CPAP versus high flow nasal cannula, and they demonstrated that the high flow nasal cannula were very good in terms that the superiority of the nasal CPAP was statistically significantly higher. And the important thing is when they analyzed the results is that the risk of fail of therapy was much higher in the high flow nasal cannula group, but mostly in the babies with severe respiratory distress syndrome. So the sicker is the baby, the more risk to fail in the babies who are given high flow nasal cannula. Of course, this is even much more important in the babies who are small, less than 32 weeks gestation. So the smaller is the baby, the sicker is the baby, the higher is the risk to fail using high flow nasal cannula. And we have even more evidence. This is a study from Dr. Conti. She, from Italy, did this systematic review, compared the effect of high flow nasal cannula compared to standard nasal CPAP. Well, they demonstrated in this meta-analysis published just a few years ago that the risk of fail with a high flow nasal cannula was statistically significantly higher compared to the standard nasal CPAP. Well, what about nasal ventilation? Well, nasal ventilation is a new way of giving respiratory support without intubated baby. Well, what is the evidence behind the use of nasal ventilation? The problem is that we don't have enough good, strong evidence about this kind of devices, because many of them are used in not very immature babies. But if you look at the last Cochrane review in 2017, 10 trials were enrolled in this review with more than 1,400 babies. Well, half of the studies were used with synchronized ventilation, half were using no synchronized ventilation, or the combination of the two. Well, but at the end, the Cochrane conclude that there is a reduce in the risk of extubation failure when these kind of devices are used instead of nasal CPAP. So probably these kind of devices are good enough to be used, at least very similar to the nasal CPAP. What is the problem? Well, the problem is those babies of less than 1,000 grams. So as you can see in this study of Burke, well, he reviewed data from babies who were randomized to be given nasal ventilation versus nasal CPAP to prevent non-invasive respiratory failure. Well, they demonstrated that at the end, there is no clear benefits of using this kind of ventilation compared to the standard nasal CPAP, but at least we must say that they are very similar. Well, what about the interface? Well, some of the times studies demonstrated the kind of ventilation that you are using, but it's not well analyzed the kind of interface. The problem with the nasal ventilation is that sometimes the interface is producing very high resistance, and the tidal volume is clearly reduced, and the baby's respiratory effort is not enough. Well, in this study published just 2 years ago, well, investigators randomized babies who were given for respiratory distress non-invasive ventilation with two different interfaces, the new RAM cannula and the short standard bronchs. Well, they demonstrated that babies who were given the standard short nasal cannulas were doing much better than with the RAM cannula. So we need to be very concerned about the kind of interfaces that we are using. And in this study, even the babies were having more need of mechanical ventilation during the first 72 hours after delivery when the RAM cannula was used. Why should be this? Well, this is another study where they compare the average amplitude of the respiratory effort of a baby using this RAM cannula. So you can see here when the baby is breathing together with the ventilator, then the amplitude is good enough. Well, when the ventilator is working and the baby is not breathing, then the amplitude is a little bit slower. But the problem is when the baby is not breathing and the ventilator breathes without the patient effort, then the resistance is too high and the average amplitude of the thorax is very low. Well, also, Professor Moretti published just 1 year ago today different analysis of the resistance of different interfaces. And as you can see, how at different flows and different pressures, the resistance of this rank cannula is much higher compared to the standard Sorbinaz approach or one of the new synchronous flow cannula they produce. So again, some of the times device is working well, but the interface is not the better way to keep this ventilation. Well, what about synchronized nasal ventilation? Well, we have not very much evidence behind the use of this kind of devices. There are few of them that can synchronize well. In this case, we have some evidence from using one of the devices that are synchronized with the respiratory air for the baby using a flow sensor. And in this study, most of them from the group of Corrado Moretti, they demonstrated that using this kind of devices, the tidal volume is increased, minute volume is much better compared to nasal CPAP. There is a reduce of synchrony, and there is a reduce of work of breathing. So probably because of this, babies are doing much better. Well, we are using this kind of device from many years from today. The good news is that babies are doing very good with this kind of flow sensor nasal ventilation. So some years ago, in 2016, we published our results in 53 patients, and we demonstrated that we could avoid to use invasive mechanical ventilation in 66% babies during the following 72 hours after delivery. So you can see we classified the babies where this device was used elective after delivery, or were you used after CPAP failure to prevent invasive ventilation. Well, as you can see in the group of the babies where this nasal synchronized ventilation were used, elective success were very high. Was as much as 90% of the babies were doing better with this kind of device. And in those babies where we gave nasal ventilation synchronized with the respiratory airflow after CPAP failure, we could prevent even 66% of the babies to be intubated. So at least in our institution, we are using this kind of basis. But of course, many times we need to be given surfactant. Because, as you know, when you don't have surfactant, you have lung atelectasia, you lose your functional residual capacity, and you have overdestation. So, look, this is a normal line of a rat with surfactant and at end expiration. And you can see how there is a very nice functional residual capacity at the end. When you don't have surfactant, at end expiration, you will see how the lung is not well recruited, and you have good areas with functional residual capacity, but other areas with a lot of atelectasia. And because of this, even if you give too much pressure by non-invasive ventilation, the babies are not going to go well. And if you give too much pressure, then the pressure is going to be probably to the good areas of the lung, producing damage in these normal lungs, and you are not going to produce any advantage because the rest of the lung is going to be closed. Well, in this kind of situation, giving more pressure or giving more oxygen, you're going probably to delay too much the open of the lung and the producing of very, very good functional residual capacity. So giving surfactant the earlier as possible is going to be probably the better way to treat these babies. But the problem is to know exactly when to give the surfactant. Most hospitals in our institution for many years are following the signal of the FiO2 needed to have the babies with more than 90% oxygen saturation. In the babies who are doing with nasal ventilation or nasal CPAP and needing more than 30% oxygen, probably this is a good signal to give the surfactant. But today we have more tools to know when to give surfactant, even probably better than the FiO2 signal. Well, this is a study done by Rebecca Gregorio from our institution. She is one of the most knowledge about lung ultrasound in premature babies. Well, she is very well trained, and she's doing this kind of studies, and now in most of our fellows and staff of our institution, we are following this strategy to look not only the FiO2 that the baby needs to be given surfactant, but also the lung ultrasound of the babies. Well, to demonstrate this, she did this very nice study published less than 1 year ago, where she looked at the babies with respiratory distress syndrome, and she did lung ultrasound in all of the babies, look after those babies who were needing surfactant. Well, what she did is to analyze and score of the lung, and the higher is the score, the more severe respiratory failure is having the baby. Well, after doing this, she compared the results in terms of needed surfactant or not. As you can see here, when she looked at the surfactant group, the lung ultrasound score was statistically significantly higher compared to those babies who didn't need surfactant. So if you look at the maximum FiO2, of course, because we gave the surfactant when the FiO2 was higher than 30%, we, of course, can see how the babies that were doing worse were having higher FiO2. But probably in the first 2 hours, when we gave the surfactant, the lung ultrasound score can help us to better analyze to whom we can give the surfactant. And today we have some studies that demonstrated that even earlier than the FiO2, lung ultrasound can give to us the signal that the babies needed surfactant. Well, she compared the ROC curve to know the sensitivity and specificity of this strategy compared to the standard FiO2. And she demonstrated that using the lung ultrasound score is more sensitivity and more probably specific to give the surfactant to qualify the baby if the baby is going to be needing surfactant or no. So today we also try to give the surfactant in a less invasive way to prevent intubation of the babies. As you know, in the late 90s of the last century, the INSURE technique, intubation surfactant administration, was very popular among most of the NICUs. But some years after, the German group described a new strategy of giving the surfactant without intubating the babies, just opening the mouth, opening the glottis, and introduce a very small catheter or any kind of small tube, and just give in a shot the surfactant while the baby is breathing spontaneously on nasal ventilation or nasal CPAP. Well, today, after many years, we have the evidence that at least this way of giving surfactant is probably better in terms of less needing of invasive ventilation compared to standard methods of giving surfactant or INSURE. In the last meta-analysis published just a few months ago, you can see that looking at the randomized control trials, or including some other studies comparing the use of this less invasive technique versus the INSURE technique, you can see how there is better results with the less invasive technique in terms of less mortality, less mechanical ventilation, less bronchopulmonary dysplasia, close to be also much better in terms of less necrotitis and enterocolitis. The rest of this data were not statistically significantly different. So at least we can say that in the short-term course, these kind of techniques are useful. But what about long-term follow-up? Well, we did this study because we have been using this technique for many years. We followed the babies that we began to use the LISA, less invasive surfactant administration, and we compare babies with the insured technique and the LISA technique. Elena Market did this follow-up study, looking at the babies after 24 months of age. What she demonstrated is that the LISA technique compared to insured was very safe because exactly no statistically significant difference in terms of neurodevelopmental outcome were in between the two versus the LISA compared to the insured technique. So we can say that in the at least 24 months of the follow-up, this technique is not producing any side effects in terms of neurodevelopmental outcome. So most of the studies have been using Khorshid as the surfactant to be given by less invasive surfactant administration. We began to use Beractan as well. As you know, the amount of surfactant is much higher, but the distribution probably is much better. So today we are using Khorshid also, but we wanted to review those studies that were using only Beractan for LISA compared to those studies that were using Beractan in the standard insured technique or a standard way of giving surfactant, to know if using this kind of surfactant also can be much better compared to the standard ways of giving surfactant. So we did this meta-analysis that we presented at the PAA's meeting in the United States last May, and we saw that using the Beractan by the LISA technique compared to a standard way of giving surfactant, that means intubate the baby and give the surfactant, was much better in terms that we can have less mechanical ventilation, and a trend to favors a little bit the combined endpoint of bronchopulmonary dysplasia or death. But also, if we compare LISA versus insured, then again, the use of Beractan by LISA is much better than insured in terms of less mechanical ventilation and less death. So at least we can say that using any kind of the approved surfactants by this technique is probably positive in terms of good results of short-term, and as I told you before, long-term effects. So at the end, I want to conclude that probably there is not one only strategy to prevent immature lung damage. It's a combination of multiple factors, and among them, trying to not intubate the baby in the delivery room, monitor and controlling the lung stabilization after delivery, giving surfactant by a less invasive respiratory technique, giving respiratory support by a less aggressive respiratory support, and using some other kind of therapies will probably improve the results of your babies. Well, Cristina Ramos from our institution, who is the person who is following all the babies with bronchopulmonary dysplasia, did this very nice study that published just 1 year ago. And she analyzed the effect of different strategies in two epochs of years, between 2012 and 13 and between 2016, when we began to use the LISA technique on 17. And she compared this group of babies, around 200 in each arm. And what she saw is that using these new strategies of like a bundle of stabilization of the baby at delivery, trying to not intubate the baby, giving surfactant early by non-invasive respiratory support, and trying to prevent lung damage will at least decrease the risk of severe BPD or moderate BPD grades 2 and 3. Please, probably this is the way that we are going to follow during the next few years. Well, in summary, the strategies to prevent lung damage are a bundle of strategies that begin to protect the lung to high oxygen exposure, to prevent trauma with too large or too small tidal volume. So we need to look at what we are doing in the lungs and control. So prevent any kind of ventilator-induced lung injury, giving airway surfactant and being the less aggressive as possible with the respiratory support. So synchronizing the respiratory effort today probably is going to be the best strategy in terms of non-invasive respiratory support, but at least all of them can produce good results in terms of stabilization of the lung and trying to prevent this kind of lung injury related to the ventilation. Well, thank you very much for your attention. It was my pleasure to be in this webinar. Thank you so much.
Well, that was an excellent talk. Before we go on to a discussion, I would like to invite all of you to the grand finale of our Learn from the Legends series, the International Neonatology Summit that we are planning to host in March. Thank you. Now, we have an excellent panel of consisting of Dr. Kamalaratnam, Professor of Neonatology from Chennai, and Professor Neeraj, again another boy in neonatology, who are going to discuss, and then we have the original legend, Professor Manuel Sánchez Luna. Thank you so much, sir. I really appreciate, and we really appreciate the in between the sessions you are just you managed to find time to join with us. Thank you so much. Now over to the moderators for the discussion.
Thank you, Professor Manoj sir. And at the outset, I would like to thank the organizers for giving us this opportunity to moderate this excellent message or talk that was given by Professor Manuel Sanchez. It was very informative, and we have and one of some of the new things that we learned is monitoring the respiratory function during resuscitation. So this is something which is new, and we are just about starting to use TP's resuscitator during resuscitation in the delivery room. We are slowly switching over to from self-inflating resuscitation back to TP's resuscitator. And I think if you go one step ahead and monitor this respiratory function, I think Sir has proved that our outcomes will be better. And many such points Sir has highlighted during his lecture. And so certain questions have come up in the question and answer box. And one of that is very interesting. What is your opinion on nebulized surfactant? And are there ongoing efforts to develop suitable catheters to effectively perform MAST?
Well, first of all, I would like to thanks again Dr. Manuel and all the organizers for giving to me the possibility of joining this meeting today. So thank you very much. It's a great pleasure for me to be here. Good evening from Madrid, Spain, to all of the people attending to the meeting. So the first question is an excellent question about the possibility of giving surfactant by nebulization. Yes, I'm sure is going to be the next step. Probably we will have the possibility of using this technique over the next year. There are some clinical trials on phase 3 demonstrating the benefits of giving nebulization, surfactant by nebulization. The idea is not to give probably to all of the babies, but to some of the babies who are prone to develop RDS and connected to a non-invasive respiratory device. Number one. And number two, probably the possibility of giving this surfactant by nebulization is another advantage that probably will keep the lung compliance working so well during more time, probably compared to a standard bolus surfactant administration. So these are the 2 points. Of course, we will have to use more amount of surfactant when you have to give it by nebulization, because you're going to lose such a quantity of surfactant not going to the lung of the baby. But you know, the advantages is, of course, the baby is going to be breathing spontaneously, very comfortable, without producing this kind of aggressive installation of the surfactant by the ELISA or mist. Because you have to remember that probably this is just one step ahead, the use of less invasive surfactant, but the near future is going to be probably nebulization of the surfactant. Yes, of course, I do agree.
Thank you, sir. I just have one more clarification regarding this. Is there a special kind of nebulizer that you use to nebulize the surfactant? And do you prefer any particular brand of surfactant for nebulized surfactant?
This is a very difficult question. Okay, we are testing different devices. Vibrating membrane are the most used nebulizer for surfactant administration. There are some studies coming from Australia, some studies coming from the United States and from Europe, demonstrating the effectivity of these kinds of devices. But today we are testing some other compressors that can produce very small molecules, less than 4 microns, to nebulize the surfactant. So in the near future, we will have the possibility of using simple, cheap, very easy to administrate surfactant. About the kind of the surfactant, well, we are beginning to test the most frequently used surfactants in Europe in the animal lab to compare exactly which should be the dilution. You know that surfactant normally given by aerosolized, you have to dilute, and the time of the nebulization and the total dose. So there are some very nice studies with Beractan coming from Michigan in the United States. Very, very nice studies with very good results. demonstrating not only the effectivity, but the absence, absolutely, of side effects of using Beractan. So in the near future, probably we will have more and more data coming from these studies.
Thank you, sir. And there is another question from Victoria Lima Rogel. With this evidence, our efforts will guide to the pregnant women for BPD prevention. Is the BPD a disease that was developed during pregnancy?
Well, this is a fantastic question. Oh my God, probably is one of the key points of BPD. So as you know, many of you, there are some different kind of BPD in premature babies. From the earlier years, remember that we were producing what we call the traumatic BPD. So traumatic BPD was related to the use of very high oxygen concentration, very large tidal volumes with very powerful ventilators. Those years disappears, thanks to God. Today, we can prevent the use of very high oxygen concentration, and we synchronize the babies. We try to control the tidal volume. So this kind of ventilator injured lung damage is decreasing and decreasing even more, and the effect of the oxygen as well. So still we have a lot of BPD. So why is that? Not only because the baby is delivered very immature, but also because there is a kind of inflammation that probably is beginning before the baby is delivered. So some of the investigators think that BPD is just a very important expression of global inflammation of the immature baby. Because as you know, the more severe cases of BPD, also those babies do have many other problems, as you know, related to neurodevelopmental, immunological problems, necrotising or enterocolitis or whatever. So it's not a simple disease of the lung. So probably some of these cases are beginning in utero. The possibility of preventing infection, preventing inflammation, decreasing the risk of sudden delivery without controlling this delivery probably will decrease some of the more severe cases of BPD. But as you know, we don't have any drug to prevent BPD in utero. Antenatal steroids do not work in terms of prevention of BPD. And there is no other drug today to be given to pregnant women to prevent BPD. But of course, we will probably find in the next few years some more evidence about the possibility that these cases, the most severe cases, are beginning before delivery of those very immature babies.
Thank you, Dr. Luna. So we have a question related to the point at which surfactant has to be given. So as you rightly pointed out that conventionally nowadays, if the baby is on CPAP of 5 and 6 and FiO2 being 30% or more, then the surfactant is being administered. So question which has been asked is that if the baby is on nasal IMV or non-invasive intermittent ventilatory ventilation, so can the same criteria be applied in terms of giving surfactant? Should the FiO2 be 30% or some other criteria should be taken to decide surfactant therapy?
So from if the question is which should be the level of FiO2 to be given surfactant when a baby is on nasal ventilation, yes, for many years, not from now, for more than 7 years, we at our institution choose FiO2 of 30% as a critical level of FiO2 to be given surfactant. Why is that? Because if a baby is needing more than 30% oxygen, this is very high oxygen concentration, and this is giving to you the signal that the lung is not open at all. So the functional residual capacity is not getting. Today, most of the hospitals, they do agree to use this FiO2 of 30%. But as I told you, probably lung ultrasound is going to improve the way we are selecting the babies to be given surfactant, because we can use the lung ultrasound earlier and before the baby is needing 30% oxygen. So the idea is not to be to give prophylactic surfactant, as you know, but to give the surfactant as earlier as possible if the baby is having incomplete functional residual capacity open. So today the combination of lung ultrasound and FIU2, the two together is going to improve results even more. Some hospitals, probably including our own hospital, do prefer to use lung ultrasound before the baby is needing more than 30% oxygen. So you can choose the two of them. The earlier is the better, of course. If lung ultrasound score is high, even if the baby is not needing 30% oxygen, this should be probably a recommendation to be given surfactant. And also, if the baby is needing 30% oxygen and the lung ultrasound score is not so high as well, probably you can choose. So the two together will probably improve the results of giving surfactant. And you have the good thing using lung ultrasound is that you can repeat as many times as you want. Because it's non-invasive, the baby tolerates it very well, and any neonatologist can learn how to use these devices that are very cheap and absolutely very confidential about results. So I do believe that 30% probably is going to be too much if you have a lung ultrasound score of lung damage higher than the level you choose.
So meaning by better to rely more on other facilities are there, the expertise is there. Short of that, we can continue to follow 30%. Till the time we develop those kind of facilities or expertise is available in the given unit. We have a question from Dr. Corrado Moretti. So this is related to the respiratory function monitoring. The first study which you showed, where you showed that the people who were not masked, so the tidal volumes were delivered very well. It was 5.8 in contrast to 7 ml per kg. And similarly, the trend was in minute ventilation. So, is that there is a very recent multi-center paper which has demonstrated that in very preterm infants receiving PPV at birth, the use of respiratory function monitor compared to no RFM as guidance for tidal volume delivery does not increase the percentage of inflations, doesn't increase the percentage of inflations in a predefined target range, whatever they have taken. So what do you think about it? So what's your take on that?
Well, this is a very good question from my very good friend Corrado. Professor Moretti is one of the most experienced person in respiratory physiology and neonates, and he's very right. When you do this kind of controlled trials, you don't find clear benefits in terms of synchronized insufflation, but there are many other advantages, as he knows, and most of the people who use the respiratory monitors at delivery. Number one, you can prevent the use of very large tidal volumes. And this is key because as I saw in the lecture, many times too large tidal volume is not only related to the risk of damage to the lung, but it's also related to neurodevelopmental problems to the baby. Number two, you can also clearly know if the baby's lung is perfused, not only ventilated. So you can open the lung, but if the lung is not well perfused, in tidal CO2 is not going to appear as a signal. So this probably is going to help to you much more to increase or do many other things that you can do in the resuscitation area. But also probably the most important things is for people who are beginning to learn and teaching how to do this kind of insufflation or resuscitation maneuvers, they can see what they are doing. This is extremely important because if not, if you are not seeing what the baby and you are doing together, probably you are going to produce more damage to the baby than the baby needs. So for me, there are many other advantages that probably are very difficult to clearly analyze in a good randomized control trial. In the trial that we did, as I show you, we clearly demonstrate that using this kind of devices, you will prevent the use of very large tidal volumes, and also you can prevent hyperventilation in the most immature babies. So I think there is enough evidence to use this kind of devices to help you how to do this transition from in utero to ex utero, and to get good pulmonary functional residual capacity in the first minute after delivery. So it's a very good question, but I think that today, most of the good hospitals doing resuscitation are going to implement the use of this kind of monitoring system, because you can see what you are doing.
Agreed. I think there is a learning. So as people start using it, they gain expertise in using it. So probably the results will automatically start coming in near future.
So there is one more extension of the question on nebulized salbutamol. They had asked whether the frequency of surfactant administration will increase with nebulized surfactant. I mean, nebulized are not salbutamol, surfactant. Nebulized surfactant, example, weekly administration to prevent BPD. Now, will the frequency of administration of surfactant increase on when you give it as a nebulized form? Can you answer that, sir?
So, which is exactly the question, because I have some problems listening to you. So the question is exactly?
Nebulized surfactant.
Yeah.
If you use it, will you have to use it more frequently? Like weekly administration?
Today we are not using nebulization of the surfactant still. We need to wait a little bit more about more evidence about the safety and effectivity of using nebulized surfactant. So, but probably in the near future, and when I'm talking about near future, yes, it's probably next year, we will use nebulized surfactant to some of the babies who are doing well, and you don't want to make this traumatic administration of surfactant like you can do it using Insure or Lysa or Mist, because you have to remember that those techniques are traumatic to the babies. So it's important to prevent this trauma if we can, and if we demonstrate that nebulization is effective, probably this is going to be the next way of giving surfactant to many of the babies. But today, yes, we are not using.
Yes. There is one more interesting question. The European guidelines says that you have to you administer surfactant based on the FI2 requirement and 30% being the cutoff. But they are wondering why was the criteria of MAP of more than 8 centimeters discarded? That's a question they have asked. Any particular reasons?
Why? Well, we never ever use a minimal pressure higher than 6 in our babies at the delivery room. If you remember, there were some trials, the famous COIN trial by Colin Morley, that they were using 8 minimal pressure, and they did have more air leak syndrome in the babies with such very high pressures. So in our experience, probably in most of the institution, if you need more than 6 of minimal pressure to open a lung at the delivery, probably that the such baby will benefit more to be given surfactant earlier instead of using such amount of minimal pressure. I must remember that some years ago, there were recommendations to be used a much higher FiO2 level to be given the surfactant, more than 60%. Well, the problem is that from those years, the administration of surfactant was related to Insure technique or standard surfactant administration. So you have to intubate the baby, connect back to the bagging system or to the ventilator, and then try to extubate. So probably because of that, many hospitals, they try to increase the umbral or the level of FiO2 or minimal pressure to be given surfactant. But today, because we can use a very simple way to be given surfactant, less invasive, we decrease FiO2 and mean pressure to lower than 30 or not more than 6. So this is probably the reason that today we are using more and more surfactant to the babies and earlier than before.
And another question is using FiO2 of 30% for at least 30 minutes a better marker to give effect?
Well,
how long do you set this target of 30%?
Well, we try to give the surfactant in the first 2 hours after delivery if we can. So again, the earlier, the better. And if the baby is needing more than 30% oxygen, more than 30 minutes, okay, this is a good indication to be given surfactant. But today in our institution, in all of those babies, we do also the lung ultrasound score. And if the combination of the two is giving to you the signal that the baby is not doing well, then we give the surfactant even earlier. So again, the 2 first hours are good timing to be given the surfactant. So waiting more than 30 minutes or half an hour or 1 hour or more is not a key point for us. So if the baby is needing that amount of oxygen, so giving the surfactant the earlier as possible is the best way. But you have to really demonstrate that the baby is well connected to the nasal ventilator, the interface is well approached or attached to the baby's nose, and everything is working well. So with that condition, if the baby is needing more than 30% oxygen, then okay, we give the surfactant as soon as possible.
We have one last question. Won't NIPPV give high maps for these babies? So you discussed overall that systematic review, the network meta-analysis where you showed NIPP was better, especially the synchronized one. So the question is related that won't NIPPV give high map for these babies?
Well, which is the question, excuse me?
NIMV.
Yes, yes, NIV.
So that is going to give high maps for these babies.
High maps. Well, high mean airway pressure, you're telling me.
Yeah.
Okay, well, we today are using more and more nasal ventilation, synchronized or not synchronized, depending on how many devices we have today in the unit. So mean airway pressure probably is not the key point because, as you know, during nasal ventilation, you have a lot of leakage. The baby is breathing spontaneously. The baby open the mouth. We have a lot of advantages, but keeping the pressure at least in 6 of CPAP or in 6 of PEEP during nasal ventilation is the way we try to do it. So again, we try to maintain during the nasal ventilation the same mean airway pressure than the CPAP. The only thing is that when you produce this signal of pressure, of course, you increase the pressure during a very short time, but this is not transmitted into the lung, as you know, in the same way as if the baby is intubated. So you never know exactly which is the mean airway pressure transmitted into the lung of the baby who is connected to non-invasive ventilator. We try to do not give more than 25 of PIP and keep the 6 as the minimal and constant CPAP level during nasal ventilation.
So one more question, that is, if you have not been able to give surfactant early, so then is there any timeline or any limit that by that time you can give surfactant later on?
Well, not at all, but you have to remember that most of the premature babies will produce their own surfactant in 2 to 3 days, as you know. So the problem is that if you prolong too much the exposure to high oxygen concentration or high tidal volumes during invasive mechanical ventilation or too high pressure during nasal ventilation, then what you are doing is damaging the lung. So of course, again, the earlier you open the lung, the better for the baby's lung. So this is the question. So of course you can wait 1.5 days if you want, but probably that baby is going to be exposed to too much risk in terms of very high FiO2 to the small areas of the lung who are open. You have to remember that when the baby is not connected to the ventilator, but breathing a very high oxygen concentration, this is because some of the areas of the lung are closed, are atelectasic. So the other, what we call the good areas of the lung, are exposed to very large tidal volumes and very high oxygen concentration. So in these areas, you are producing a tremendous inflammation. So the earlier you improve the lung volume, the better for the baby. So this is the comment. So this is the question. So do not damage the good areas of the lung too much.
So one last question from my side. I just want to know, are you using NIMV as a primary mode in your unit? Like you have stabilized the baby on TPC resuscitator in the delivery?
Well, today, yes.
Yeah. And then given surfactant based on your ultrasound or FiO2 or a combination of whatever criteria. Now, suppose the baby is not maintaining, the baby has still increased volume of breathing. So let's say that you have a 27-week baby and you have given surfactant at 1.5 hours of age. And now you're sitting at a CPAP of 6 centimeter, FiO2 being around 40 to 45% with still Silverman and Anderson score maybe around 2 or 3. So in this situation, do you shift them to NIPPV or you directly intubate these babies?
Well, we try to use nasal ventilation instead of CPAP in most of the more immature babies because we know that we will decrease the dead space of the mouth and the nasopharyngeal area just because you are ventilated. So you decrease probably the rebreathing of expiratory CO2 that the baby is breathing spontaneously when the baby is on nasal CPAP, number one. Number two, you are signaling the baby to breathe spontaneously. So we do prefer to use nasal ventilation in most of the babies today. Of course, if the baby is doing well and doing well with the nasal CPAP, standard CPAP, then we keep the baby on nasal CPAP. But if the baby is not doing well, or the baby is very immature, then we put the baby very fast to nasal ventilation. And if the baby still needs higher FiO2 than 30%, or the lung ultrasound is giving to us the signal that the baby's lung is collapsed, then we give surfactant very early. And we keep the baby on nasal ventilation after the surfactant administration as well.
And sir, what is the interface do you use? You prefer the mask or do you prefer short nasal prongs?
Oh, we are using both. Well, the problem, as you know, the short nasal prongs works very well, but the risk of nasal trauma is high. So today we are using the two of them. In the smaller babies, we use nasal mask, working so well, so good. Absolutely. In those babies, we try to move or modify, many times a day to prevent even damage to the nose with a mask. But as I show you in this meta-analysis, there are good data showing us that these nasal masks works very well compared to the nasal prongs. So the two together.
Okay, thank you. Sir, sir.
So there is one last question. Do we have one last question is there or should we close it?
It's up to Prof Luna.
Okay, so sir, last question. What is
Yes,
the criteria for repeat surfactant and when do you repeat?
Okay, so we have a very strict protocol. So if after giving surfactant during the next 6 hours, the babies needed more than 40% oxygen, then we repeat the surfactant by less invasive surfactant administration again. So if the baby after the second dose still needs higher FiO2, then probably we intubate the baby. This is the criteria. After the first dose, we choose a little bit higher, 40% oxygen to give the second dose.
So sir, do you don't take pressures into account for deciding the second dose apart from FiO2?
Oh, excuse me, do I? We will.
So do you take mean airway pressure also into account apart from FiO2 to decide second dose?
No, not at all. We keep exactly the same mean airway pressure as before. So we don't move the mean airway pressure. We just look at the baby, and if the baby is doing well, then we keep the baby on the nasal ventilator. If the baby is needing more than 30% after the second dose, we look very closely to the baby. When the baby is reaching more than 40%, then we repeat the dose of surfactant.
Thank you so much.
Thank you, sir. Thank you so much. Very enlightening lecture. And in fact, many new things we had come to know about managing a extremely preterm baby, the ventilatory support part of it. And it was heartening to know that bubble CPAP is still better than most of the other forms of CPAP. And we can give minimally invasive surfactant using Baractant. We were wondering that should we change the type of surfactant? Should we use only Boractant or porcine surfactant for Lisa? But from your study, it has shown that Baractant also can be used to give minimally invasive surfactant. And thank you, sir, for the excellent way you cleared all our doubts, the questions. And thank you so much. Sir, Manoj, sir, over to Professor Manoj.
Thank you, sir. So, as we say every time, the all sweet things need to come to an end. If you engage Professor Luna, then we can spend the whole night because he's so good at this. And we had a taste of his lecture first time in HFO. So, if you remember last year. Yeah. And exactly 1 year now we are hearing again from you. Such a huge honor, and we truly hope that the travel restrictions getting relaxed. We hope to meet you in person during the grand final, the IAP Neocon, which you have kindly agreed to come physically if things are in a good shape. So we hope to see you, sir, in March. Thank you so much, Professor Luna. You were hopping in between sessions today, and really thankful to you for finding time for us. Thank you.
Thank you very much.
Thank you so much.
Thank you so much.
I would also like to thank you. I would also like to thank Professor Kamalatnam and Professor Neeraj Gupta. Wonderful moderation, and then I knew that you had to cut short so many questions because the time is a very big limiting factor. And anyway, we had wonderful time. At the end, let me thank all of you, dear attendees. We have so many of you have joined us here in Zoom, YouTube, etc. now live, and then the next 24 hours our viewership is going to be quite high. So we are truly honored to have you all with us. More than 8,000 registrations now. And it's such a huge honor because of these legends, we are able to continue the series. So let's go on to the next one in the series. That is going to be, as we were saying previously, we will be discussing mostly preterm care in the coming days. So it is going to be preterm care that we are going to discuss. So like in the next session that is going to come up on 25th of November, Thursday, we are going to continue from Professor Luna's the talk. The talk will be on optimization of preterm birth, current concepts and future perspectives by Professor Sundeep Harigopal, Newcastle University, UK. We continue the series. The next 3 topics are going to be on preterm. On 9 December, we have Advanced in Management of ROP by Professor Hellström from Sweden. And then on 23rd December, we have Neuroprotection Preterm Infants by Professor Khorshid Mohammad, University of Calgary, Canada, who is instrumental in forming the Canadian guidelines for the same. So, thank you all for joining, and have a good day, good night.
Thank you. Thank you, sir.
Thank you.
Thank you.